Welcome to the RSNA Radiographics Podcast. I'm Brandy Griffith, a breast radiologist at The Ohio State University in Columbus, Ohio, and the first author of the recently published radiographics article titled Applying the Contrast Enhanced Mammography BI-RADS Lexicon to Clinical Practice. I'm here today with the senior author of the paper and my colleague, Mitva Patel, who is also a breast radiologist at our institution and clinical director of contrast enhanced mammography.
Thank you, Brandy. We're excited to highlight some of the key points from our article and walk you through how to apply the ACR BI-RADS contrast enhanced mammography lexicon into clinical practice.
And I think it's important to start with why we wrote this paper. Contrast enhanced mammography, which we'll refer to as CEM, is still a relatively new modality for many radiologists, and there's a learning curve when you first start using it and interpreting studies.
We heard that feedback a lot, that CEM felt intimidating. It's a newer modality with its own lexicon, and you're essentially doing two things at once. You're reading mammography and evaluating enhancement on recombined images, which in many ways resembles interpreting MRI.
Exactly. And we wanted to emphasize is that if you're already comfortable with mammography and breast MRI, you actually have most of the tools you need to interpret CEM. The CEM BI-RADS lexicon intentionally borrows from both, and our goal was to show that connection so people feel more confident adopting it.
And consistent use of the lexicon really matters, not just for individual interpretation, but for communication with referring clinicians, for research, and for future growth of CEM as modality. Okay, a quick review of what CEM is before getting into the details of what the paper might help. Brandy, could you please explain what contrast enhanced mammography is and how it's obtained?
Contrast enhanced mammography, or CEM, is a functional breast imaging study, often compared to contrast enhanced breast MRI. CEM is performed using standard mammography equipment that has a specific filter and software to allow CEM to be performed. Iodinated contrast is given intravenously, and then the mammogram images are obtained in the standard views that we use for screening and diagnostic mammography. A dual energy technique generates low energy and high energy mammograms. The low energy image looks similar to a full field digital mammogram, and the high energy image, also called the recombined image, shows areas of contrast enhancement. So at the end of a standard bilateral CEM exam with craniocaudal and medial-lateral oblique views, you would have 8 2D images to review. Also, tomosynthesis can still be performed before or after the CEM.
Right. Throughout this discussion, we're going to refer to the images that show contrast enhancement as the recombined images. A good place to start when talking about interpreting recombined images is looking at background parenchymal enhancement, or BPE. Just like on breast MRI, BPE on CEM refers to normal enhancement of fibroglandular tissue.
And the terminology is the same as MRI. So BPE is classified as minimal, mild, moderate, or marked, and is described based on the relative amount of enhancement and not the total volume. The symmetry of BPE between the two breasts is also assessed. Most patients undergoing a CEM will have minimal or mild BPE, which is helpful because higher levels of BPE can obscure enhancing cancers, reducing both sensitivity and specificity. Studies are currently being performed to determine whether marked BPE is related to false positive and false negative interpretations.
Okay, great. Now on to interpretation. When reading CEM, you can have findings seen on the low energy images only, the recombined images only, or both. The low energy images are essentially a full field digital mammography image, and so you can use the BI-RADS mammography lexicon and interpret those findings just as you would on a standard mammogram.
Exactly. An important point we cover in the paper is the management of calcifications, which should be based on the low energy images and magnification views. Studies suggest that if there's no enhancement associated with calcifications, they may still be malignant. Also, enhancement associated with calcifications could be a false positive finding. A study from Chung and colleagues found for 13.4% of non-malignant calcifications had associated enhancement. Therefore, CEM should not be used to evaluate microcalcifications.
It's also important to remember that the most suspicious finding drives management. So masses, architectural distortion, and asymmetries should be addressed the same way that they are addressed on conventional mammograms. The presence or absence of enhancement can help guide decision-making, but should not be the only factor in decision-making. Now, what about findings seen on recombined images only?
So, one important concept that we cover in the paper is that there are findings on contrast enhanced mammography that are only seen on your recombined images, and these should not be ignored.
That's right. There's certain findings that are only seen on the post-contrast recombined images, and these findings may also represent a malignancy. A study by Kim and colleagues found that a quarter of recombined only findings were malignant. So these findings cannot just be dismissed. We have to investigate them further.
So for these recombined only findings, the CEM BI-RADS lexicon is used, and the lesions are categorized as masses, non-mass enhancement, or enhancing asymmetry, which is a new term unique to CEM.
Let's take a minute to talk about new terminology. You mentioned enhancing asymmetry. Can you explain that term?
Enhancing asymmetry refers to enhancement seen on a single recombined image, with or without a low energy correlate. So there's no direct MRI equivalent because MRI is a 3D or a volumetric exam, and CEM is 2D. So it is possible to see enhancement on only one view on the CEM. In a retrospective review, enhancing asymmetries on CEM had a positive predictive value of 18%. Therefore, biopsy should be considered for enhancing asymmetries.
Two other new terms to describe enhancing findings on CEM introduced in the lexicon are lesion conspicuity and extensive enhancement.
Yeah, so lesion conspicuity describes lesion enhancement compared to the background enhancement, and it's characterized as low, moderate, or high. So, although data are still emerging, studies suggest that high lesion conspicuity may be associated with more aggressive tumor biology, but more research is needed.
Another new term in the CEM lexicon is extensive enhancement, and this really helps us describe how the enhancement relates to what we're seeing on the low energy images. So essentially, we're asking, how does the enhancement compare to the size of the mammographic finding? There are four categories. A lesion can be partially enhancing, only part of the mammographic lesion enhances. It could be completely enhancing, where the enhancement matches the lesion on the low energy images. We could also see enhancement extending beyond the mammographic lesion, which, if malignant, can suggest more extensive disease than what's apparent on the low energy images. And finally, there are cases where there's no enhancement of the mammographic lesion itself, but there is enhancement of the adjacent tissue, which could be seen in inflamed cysts or fat necrosis.
So, we've discussed findings on the low energy images only and the recombined images only. But what about findings on the low energy images that have associated enhancement on the recombined images?
Studies suggest that enhancing lesions are more likely to be malignant when there's a corresponding finding on the low energy images, with mass enhancement carrying the highest positive predictive value. In addition, the degree of enhancement tends to correlate with tumor biology. Invasive carcinomas and DCIS often demonstrate stronger enhancement when the tumors are larger in size or higher in grade.
So, what are some of the possible causes of false negative CEM?
Small tumor size and low tumor grade can make breast cancers more difficult to detect on CEM. Certain breast cancer subtypes can be particularly challenging, like invasive lobular carcinoma and mucinous carcinomas.
For example, invasive lobular carcinoma often has an infiltrative growth pattern. So, instead of forming a discrete mass, it may present as subtle diffuse changes in the tissue or architectural distortion. On the recombined images, invasive lobular carcinomas can appear as focal non-mass enhancement, and sometimes it's only visible on a single projection.
Mucinous carcinomas can also be challenging. They may appear as circumscribed masses and can show weak or even no enhancement.
So, if suspicious findings are found on the low energy images that don't enhance, should you base decision to biopsy on the most suspicious imaging features?
Definitely. As we previously mentioned, higher degrees of BPE can obscure and enhancing cancer, so carefully analyze the low energy images and have a high level of suspicion when reviewing the recombined images. Also, having a low threshold for using breast ultrasound may improve accuracy.
Okay, so what do you do if you identify a suspicious finding only on the recombined images?
You can use diagnostic mammography, tomosynthesis, and ultrasound to identify a correlate. A correlate can be identified in the majority of cases.
What if a correlate isn't found?
If available, CEM biopsy can be performed. If not available, a BI-RADS 0 assessment may be used to recommend breast MRI for further evaluation. And the report should clearly state what the next step would be if the breast MRI is negative. However, if CEM finding is suspicious enough that an MRI is being obtained specifically to guide a biopsy, then a BI-RADS 4 or 5 assessment is more appropriate.
If MRI is not available and the findings are of low suspicion, a short interval follow up CEM may be appropriate. However, it's important to know that there's no data to guide which recombined only findings fall into this BI-RADS 3 category. But if the enhancing finding is very suspicious, stereotactic biopsy may be attempted using tissue landmarks.
Another interesting area we discuss in the paper is the potential role of contrast enhanced mammography in reducing unnecessary biopsies, particularly for low suspicious BI-RADS 4 lesions.
And this is an area where more data is needed Small retrospective studies suggest that CEM has the potential to reduce benign biopsies of low suspicion masses and architectural distortion that don't enhance, as these were unlikely to be malignant. But that said, it's important to emphasize that this approach isn't ready for routine clinical use yet. Additional prospective studies are needed to validate these findings before changes to management can be recommended.
We've touched on the major takeaways, but there's a lot more nuance and many more examples in the article itself, so we hope you take a look at the full paper in radiographics.
Thanks to the authors of this article, including all of our co authors, Clayton Taylor, Jeffrey Hawley, Narev Chauhan, Ian Klonk, and Candace Ferguson, for their contributions to this work.
If you've enjoyed this episode, please remember to rate, review, and subscribe to the Radiographics podcast. It really helps others find the show.
Thank you so much for listening, and we hope you'll join again for another episode of the RSNA Radiographics podcast.